Good evening. On behalf of the Learning Affairs Committee of the ESTS, it's a pleasure to welcome you to the last webinar of the ESTS series before the summer break. And it's a great pleasure to have today Hans van Weer with us. He's working in Leuven with a strong focus on chest wall surgery, and last year he has organized a very successful ESTS chest wall surgery course. And it's a great pleasure today to have him talk about innovations in pectus surgery. As always, you have the possibility to ask your questions via the chat function, and there will also be some polls included. So I kindly ask you to participate in these and to have a very interactive session. Okay, Hans, thank you very much for being with us, and we're looking forward to your presentation.
Thank you, Clemens, for the nice introduction. I will share my screen. And if all goes well, you're all able to see my screen. So thank you to the ESTS board to the educational committee to invite me to give you a lecture on innovations in pectus surgery. And if you permit me to say, the real high mass is in about a month's time, when we will have the CWIC Congress, which is 3 days dedicated to all different types of chest wall pathologies. So I hope I will be able to give you at least a summary on what's going on in our field, and hopefully you will be able to take some key messages back home. So let's start. For the confirmation of the UMS, I have 2 conflicts of interest to report. And for those of you who don't know where Belgium is, well, this is this little tiny red dot on the world map. That is Belgium. You might know Belgium as a very complex country with a lot of different languages, but it's also the home country of Gustav, who was the 7th runner-up on the Eurovision Song Contest of last week. It's also known as the beer capital of the world, as the headquarters of Anheuser-Busch InBev is situated in our city. And for those of you that already were in Leuven, this is a nice Gothic town hall that you can find on the Central Market Square. Really worthwhile a visit. This is my hospital. We're still refurbishing and building new buildings. I don't know what we will do with all these buildings, but anyway, you see that the cranes are working. And hopefully this crane will come somewhere back in my presentation as well. These are my colleagues for the time being in the Department of Thoracic Surgery here in Leuven. And as Clemens already alluded to, my main focus is, besides esophageal care, also on chest wall pathology. So let's go for the first question to get you a little bit entangled with my presentation. How are you attending this webinar? As a consultant surgeon, performing already chest wall surgeries, as a consultant surgeon interested but not yet or not a lot performing, or as a junior surgeon just willing to know more about this type of thoracic surgery? So the poll is open, and you can do that in the side of your screen. You might have to tick the little boxes on the right below corner and activate polls. There's a little red number 1 activated.
Yeah, people are already actively participating. The majority is consultants performing chest wall surgery.
Okay,
and,
so I cannot freely speak anymore because I have some experts in this expert talk. Good. The next question. So especially for those doing it, this type of surgeries already, what type of operations are you performing? And you can answer multiple options: a Nuss, Abramson, Ravage, sandwich, or bracing. interestingly, because a lot of people, about 1/3, is performing still ravage procedures. I think this is interesting, and I'm very happy that I included some data on that as well. Okay, let's go to the last of the first 3 questions. What is the age of patients that you treat in your center under your care? Again, multiple answers are possible. So, and it turns out that about half of the participants is treating patients between actually 16 and 25, and only a smaller amount of respondents are treating older patients up than 25. Okay, let's crack on. So in my talk, I will handle 4 main topics. I was asked to talk about innovations in pectus surgery, and I will try to handle some highlights on physiopathology, on diagnostics, innovations in implants, and last but not least, innovations in techniques. So as an introduction, you might all know that the sternum, which is basically the center and the cornerstone of this type of surgeries, is actually a combination, a puzzle of 5 or sometimes even 6 little pieces, which are assembled together in accordance to the growth spurt. Due to the hormonal actions, some parts fuse earlier than others. And this plays a major role in the occurrence of the existence of chest wall pathology. Castello, an Argentinian surgeon, tried to classify the chest wall disorders in 5 types. And as this talk will handle mostly about pectus surgeries, we will talk about most of the time the cartilaginous chest wall disorders. I will not talk about Jeune because this is a very complex, very seldom pathology. And Poland syndrome, I will touch it very briefly, but this is sometimes seen in people with high volume chest wall clinic. Currarino Silverman, or pectus arcuatum as it is also known, is a bit more frequent as it is considered to be a variant between pectus carinatum and excavatum. What are currently the indications to go for surgery for pectus? Well, for pectus excavatum, we currently still consider a Haller index higher than 3 to 3.25, or more recently we talk about a correction index, which should be more than 28% of worthwhile to consider for surgery. That is just on the anatomical landmarks, but more importantly, in regards to the cardiopulmonary effects of the pectus excavatum, reasons to embark on surgery are also restrictive pulmonary disease, cardiac compression on the right heart, and a shift of the heart into the left thorax, usually subsequent to the previous reason. When there's progression of the deformity as well as pain at chest wall level, this is often also a reason to pursue surgery. And last but not least, we see that also the disturbance of the body image in usually the youngsters are a reason to go for surgery, albeit said that this is very predominant present with pectus excavatum, but this is mostly the reason for treatment for pectus carinatum patients. Now, when we have to talk about innovations, we cannot deny the history of the surgeries in our field. And here you see an attempt to establish a timeline in where actually the innovations were created in the past. And you see we're a very young niche with Meyer in the early days of the previous century, starting with the removal of the second and the third costal cartilage. And then you have Sauerbruch, and the most renowned, next to Dr. Nuss, surgeon in this list is Mark Ravitch, who described, or at least published, his experience with his technique of the resection of the transection of the cartilaginous joints in 1949. Some variations on the theme of Ravitch were established throughout the years later. And then the next important landmark is obviously Donald Nuss, him introducing a less aggressive way to tackle deformations of the anterior chest wall. If we then come more to the recent years, we see that the less invasive methods go on further with the introduction of the dynamic compression system by Marcelo Martinez Ferro, as well as the introduction of the vacuum belt by Ernst Klöber. Always considered to be a variant of Nuss, but actually they worked on it parallel to each other, is the introduction of the Abramson procedure by Horacio Abramson from Argentina, as the pectus carinatum deformities are fast more present in the south of the America regions. And as you see, the older techniques, they could be used for the two main predominant chest wall deformities, but lately the selection of these techniques were actually limited to one of the two. How and what do we do here in Leuven? You see that in alignment to the historical line that we saw in the previous plot, you see that also in the past, my predecessors, Professor Stalpaert, Professor Lurrit, and Professor Koosmans, they embarked already quite some time ago on the Ravitch procedure, which was until the years 2002, 2003, the standard for surgical treatment of a chest wall deformity. And in 2002, but it's a bit hidden behind the blue blocks of the Ravitch, Willy Koosmans started here in Leuven with the introduction of the Nuss procedure. And since then, the technique became more and more popular, knowing that since 2011, there's also a partial reimbursement of the implants. And since then, we have experienced a vast growth of the activity, including also the start of bracing therapy about 4 to 5 years ago. Now, obviously, when we talk about Nuss procedure, Donald Nuss is omnipresent, I think, in this discussion, because he set out the landmarks of a less aggressive way in the reduction of an anterior chest wall deformity. And that made that also people with less physical symptoms came into the eye of an option for surgical repair. And the innovative part was that, although I was told that in the beginning the camera was not introduced, the innovative part is that actually there's a scaffolding built under the sternum which takes its support actually a bit more medial on the highest point to lever up the sternum towards the front. Pectus excavatum is existing in 3 predominant forms, which we consider to be in 2/3 of the cases cup-shaped. About 1/5 is a pen or saucer-shaped, and then the 10% trench or Grand Canyon, as we call it as well. I've mentioned briefly during the introduction the pectus arcuatum being actually a hybrid form between the two, and more we see that also the treatment is existing in hybrid techniques. Now, what is also very interesting is that in female patients, sometimes the pectus excavatum deformity is a bit tucked away and hidden because of the breast formation. But this is one of our own patients that you can clearly see that this is not a normal female chest. And knowing that these ladies at the age of 14, 15 years old are almost fully grown adults, as they are a bit earlier in their growth spurt, you can understand that even these girls, despite being tucked away behind some more layers of clothing, they also experience the same physiological problems, but even more the appearance and the disturbance of the self-image. So, as an introduction, now I want to embark on the first part of the innovation of my talk, and that is on the physiopathology. But maybe I should state that in the last couple of years, we gained some more insights, because in the beginning, we were operating on patients with chest wall deformities, but still, even nowadays, I experience myself, and I'm sure that other colleagues throughout the globe experience the same, that we need to sometimes convince general practitioners, pediatricians, not pediatric surgeons, because they do these operations, they see these patients in their clinics, and also cardiologists, despite the fact that I will hopefully be able to show you that the heart is really in the center of the problem. And the aha-erlebnis, as we call it in German, came quite some years ago, but only found some regain given the ongoing and more aggressive discussion that we experience as healthcare providers with the insurance companies. And so bit by bit, the chest wall community tried to find some more objective measures to defend their decisions to help patients, usually very young patients with sometimes more limited physiological problems. And as I will show you a bit later on, there is a shift in symptomatology. And this paper of the group of Don Jaroszewski of the Mayo Clinic is already in one eye, even for surgeons, very clear. You can see here a pre-correction transesophageal echocardiography, where you see that there is a deformation of the right ventricle, and in minor issue also of the right atrium and the mitral valve. Now, after repair, you see that there's a nice convex regain of the form of this right ventricle. Now, the fact is that obviously we have to do in this patient a transesophageal ultrasound, and this is a study example. So the community is further looking to find some more objective measures. Despite that, we were still stuck. This was an adult patient, and here you can see actually the same findings of the group of Manuel Lopez in Barcelona, where Anna Lain also did actually the same, but in young patients. And we see here, before operation, two-dimensional ultrasound cubes of the right ventricle and diastolic dilation, the right atrial diameter, and the tricuspid annulus diameter. And you see that the diameters and the distances measured, they increase during the procedure and stay higher than before after correction. And that is also here seen in this graph, where you see the pre and the post assessments in the 20 different patients that were assessed on the same levels, that there's a clear increase at the final phase. So patients gain more place for their heart. So the conclusion of these researchers was that the preoperative transthoracic echocardiography at rest, because it's usually done at rest, underestimates the compression on the right chamber. And if you talk to these patients, they will they will predominantly experience shortness of breath after or during exercise, not when they're zapping to the television or playing their PlayStation. Moreover, they have shown also that the surgical correction improves the diameters of the heart structures that are necessary to pump blood towards the lungs. Because of the fact that the muscle is very thin and slim, this part of the heart is very prone for deformation by external chest wall compression. Again, these are findings on the transesophageal echocardiogram perioperatively, and so the hunt pursues to find some more findings that we can use from the preoperative setting. I will come to that shortly after. Now, these were echoes with young patients. Are there more things to see or similar things to see with older patients? Because those of you that see patients in their clinics, they see obviously the adolescent target population, but more and more we see also adult patients that were overlooked at the time or were not offered any correction or even did not have any problems at the time of their adolescence. But we see that when they become older, there is more and more physiological impairment. And this is shown in this nice study of Dr. Brown of the United States, where we see that the right ventricle and the left ventricle are subjected to deformation, and as such, patients perform less well compared to the adolescent patient category. There is, however, also not only the interaction between doing assessments at rest and at exertion, but there's also the role of breathing. In this investigation, the researchers found that there's a vast increase when patients breathe in very deeply and hold their breath. The Haller index will change, and the Haller index, I will come to that in the next few slides, is a determination of the depth of your pectus excavatum. So basically, we should come to some sort of standardization on all the assessments we do to assess the depth and the invasiveness of the pectus. So, and that is the pathophysiology. I think it's clear now that the heart is in the middle of the problem. But how do we come to the diagnoses? And an ultrasound perioperatively, as I said, you have taken already the decision to do something. And as I'm also an esophageal surgeon, I'd like to stay out of the esophagus when it's not necessary, but that does not solve the initial posed question. So, and in order to avoid radiation, we see now a revisiting of the 3D external scanning. The group of Manuel Lopez was and in Saint-Étienne was very occupied with that about 10 years ago. Then the activity lowered out a little bit, and now recently there's a revamp, if you want, of this type of non-invasive technique. Now, if you look only to the photographic evaluation of chest wall deformities in a research that was performed by the Zuiderland group in Heerlen in the Netherlands, we saw that the visual assessment of depth and width of pectus excavatum patients that were proposed to expert surgeons did not seem to have a good intra and inter-observer agreement. So as such, only photographic evaluation appears not to be a very objective measure to come to a good assessment. What about the indices? We know already for quite some time the Haller index, which is actually a division of the inner width of your chest wall divided by the shortest distance between the vertebra and the deepest point of your sternum. By doing so, you get an equation, and if you in the past considered that, because Haller was a pediatric radiologist, he wanted to give some guidance on who to operate and who not. Well, if you take some control patients and patients as such with a non-chest wall deformity, then you see that there's quite some overlap between normals and affected patients. So as such, there's not a good, very discriminatory ability, and I will show you in the next slide why that is. So as a further refinement, in quite some in recent years, we came up with a correction index, and despite the fact that it's getting more and more useful, I see that in even recent papers, still the Haller index is cited. So what is the more refinement is that also the highest point of the chest wall is taken into account, and as such, any asymmetry of the chest is also taken into account. What you see is that the correction index can discriminate a lot better in those same group of control patients in comparison to affected patients. And as I said, this is not a graph indicating any reason for treatment, but you see with a correction index of 28%, which was similar to the initial Haller index of 325, we see that we have a good place to embark onto. I want to elucidate a little bit why I'm a bit in a bad relationship with the Haller index. Here you see two chests with a Haller index, with a very high Haller index, 4.4 on the left side, and actually a considered to be low Haller index of 2.6. And according to current guidelines between brackets, the right patient will not be amenable for any surgery as being lower than 325. But when you start calculating the correction index, you see that these patients have a completely reversed percentage. And as such, I think it's clear which patient deserves treatment. So that is about indices, and obviously the work will have to go further on that. And now, because of ionizing radiation should or can be avoided, and external scanning alone is not sufficient based on photographs, MRI, I think, is the next place or the next investigation to consider. And in a recent paper of last year, we see that some thoracic indexes were computed in a semi-automated way, where researchers have also written some software that can be fetched from the internet even, and ran on MRI images. And here they come up with a volumetric correction index. It's a little bit MRI derivative of the earlier mentioned correction index. Here you see the computed internal delineations, and then the correction in the internal MRI correction index is calculated, and you see that there's a good correlation coefficient between the Haller and the correction index, and obviously the correction index is a little bit higher as it is more reliable on its own. Is there now a way to avoid the logistics that have a look with the MRI as well? Yes, if we go back to the 3D scanner, also from the group of Barcelona, they did a correlation between, again, the Haller index. So I would be curious if the group of Manuel could try to do the same research, but now on the correction index, whether there was a correlation possible between the calculator Haller index, so all these patients had CT graphic evaluation, and an external scan. Bear in mind that on the CT scan, you can see the internal delineations, but on the 3D scan, it's an outer image, so you need to take into account also the skin and the eventual subcutaneous fat. Now, we all know, as treating these type of patients, that these are usually very lean patients, and that it will not make such a big difference. But anyways, what the group of Barcelona found is that there was a significant correlation between the, if you want, radiological Haller index based on CT and external Haller index. So there is, I think, not on photographic evaluation, but on 3D scanning, there is indeed a place to find some correlation and put a more objective assessment on who to operate. And more recently, the external Titanic index, which is a derivative of the internal CT Titanic index. I think it's a very nice name. And if I'm correct, I think Marcelo Martinez Ferro came up last year with this, or a bit more recent, with this type of index. At least then I heard of it. And actually, it makes a difference between what the ideal direction of the breastbone should be, and makes, again, a division with the complete sternal length and the part of the sternum that is sunken under the line of level. If we go further on the 3D imaging, the group of Heerlen also was very active in this field, and in a very recent published paper, Jean Damen aimed to show that if you make a correlation between the CT scan and the cardiac compression, there is a possibility that you can make a prediction model based on the CT scan of their center. Now, obviously, this is a single center model, and these findings need to be externally validated as well. But at least there is some activity in this field to avoid any radiological assessment of the chest wall deformities. I know I was talking a lot of pectus excavatum less on pectus carinatum, but as you can understand, a lot of insurance companies are willing to pay for or not pay for the most occurring chest wall deformity, and that is pectus excavatum, at least in the US and in Europe. What about innovations in implants? I think it's not my favorite implant, but to give you a complete overview of the innovations of the last couple of years, this is a 3D prosthesis in silicone, designed and based on a CT reconstructed 3D image of the chest wall, in trying to, in this patient, get her pectus arcuatum better corrected. Knowing that this is obviously only a cosmetic correction and will not take any improvement in the functional outcomes. Obviously, you need to have a scar, and the scar is in this lady here in the middle. Obviously, it's very nice healed up, because these wounds are sutured by plastic surgeons. They are the masters in that. But I think, in my personal opinion, this is indeed a very good option after failure, after redo surgery for chest wall deformities. I'm not that inclined to say that this should be the first thing to embark. I try always to find, especially in adults, to find physiological reasons to be able to tell them that it's worthwhile to go through not a cosmetic alone, but also a functional recovering operation. What else is on the market? Well, it's this type of bar is on the market, but not in Europe. So I'm sorry for all my European colleagues, but this has only been commercialized, unless I'm wrong, in the United States for now. And Zimmer Biomet, the first introducers of the pectus Lorentz bar, and they came up with two major improvements. They changed the steel bar to a titanium bar, and they made a different mechanism at the level of the stabilizers. You see, there are no indentations anymore where we had to put a metal thread to avoid slippage. Now it's a fixation with a screw, with a locking screw, but more importantly, the stabilizer is put on the front aspect of the bar. I will not discuss the biomechanics, because I don't have any data on how this was investigated and how the company came to this decision to make and produce and market this design. But at least this is now in the US, I was told, for about $4,000 per bar, but maybe some US colleagues here present in the audience will be able to tell me more updated prices. Now, having said that, so why did they embark on titanium implants and got rid of the steel? Well, in the surgical steel, that's an alloy, it's alloy ESTS 501. There's always a little bit of chromium and nickel present, and that is held responsible for nickel allergy in some patients. You know that some manufacturers, they provide a little nickel block to put on the skin. Now, I was told by my dermatologist that this should not always be taken for serious. However, I was already able to avoid some disasters by doing some pre-op testing of the skin. The company states that the pre-pen bars help to reduce the OR time. On the other hand, I think it takes an experienced surgeon 20 seconds to have a good bar, and moreover, all these bars have a symmetric bend. And what do you do then if you need an asymmetric bend, because titanium is not so nice or does not respond that well for unbending? The company states also that there are no indentations, so there's less ingrowth. That's probably possible. I cannot make any comments on that. And the titanium, known to be a bit more weaker than the steel, is apparently pre-treated to reduce slippage and to reduce the fatigue of the implant, whilst reducing the pectus. I have some thoughts, however. Steel is stiffer, but I don't have the material available, so I cannot make any user comments on that. I must say that hardware failure of a bar I've never seen, but yes, stabilizers, they can break due to the friction forces that are present. On the pre-bend shape, I already made my initial thoughts, and I will show you some more in the technique section. What about oblique bars? Well, I think for those of you know grown up with the chest wall and the Nuss procedure, this is the classical position with a horizontal bar and one or two stabilizers. Some people prefer some longer bars and no stabilizers. I think it's a bit variation on the same theme. But if your the most deep point of depression is somewhere here in the middle, you will miss the bar. You will miss the bullseye with the bar, as stated quite some time ago already by Hans Pillegaard from Denmark. And as such, sometimes an oblique position can be necessary to have a bullseye under your chest wall, under the deepest point of your chest wall depression. Now, what you then see is, because of the fact that the intercostal spaces are a bit wider here in the front, you see that sometimes the stabilizer with its limited length is only taking support on or the superior part of or the overlying rib, or when you put it a bit more lateral, on the underlying rib. But you lose some more stability on this part of the stabilizer. And really, sometimes you cannot rely always on the second stabilizer, because if the bar tends to slide a little bit to the right side, also this stabilizer will lose grip. Obviously, you can prefer a longer bar, but again, then it's more positioned towards the lateral, or to the lateral axillary line, and people are quite uncomfortable when they lie on that. So as such, Biomet came up with an asymmetrical stabilizer, which I've seen, but I could not find any footage on that, but I know it exists in the same titanium alloy as you've seen in the previous slide. A more recent technique to tackle pectus excavatum is a pectus up technique, marketed by Ventura Medical of Spain. And it's a relative new implant which is brought in through a horizontal skin incision just above the deepest point of the depression. And because of the fact that this is actually an external thoracic implant, there's no need for a thoracoscopy. What it does basically is it puts a little plate with 4 screws onto the sometimes rotated sternum. And then with this handle, this traction plate is picked up. And as this reposition plate is positioned actually a little bit like the Nuss bar on the most highest point of the deformation, you actually bring up the sternum towards this plate. This plate needs to be removed after quite some time, but as this is a very relative young technique, I think we still need to see what it brings out on the long term. More and more surgeons are embarking on that, especially in Spain, Latin America, and a couple of colleagues also in France. I promised the surgeons about, what was it, the third of surgeons doing the Ravage procedure, that I will not forget them. These are the original designs of Mark Ravage in the Annals of Surgery of 1949, and a little bit of trivia, but he was also one of the co-founders of United States Surgical Company, now being Medtronic with the staple technology, as we all know. To give you an example of one of my own patients, this is a young lady, of 21 years old, almost with 3 breasts, with a very protruding pectus carinatum, and she came for better appearance. Obviously, this is the profile X-ray, and you see a very, very protruding sternum. And if you take this schematically, you can already see that the sternum needs to lose 1 or 2 triangular parts. And if you bring these parts together, you get back a normal orientation of the sternum. Now, what do we need to do? We need to bring the sternum together. In the past, we did this with steel wires, and in the original papers of Ravage, there was also a retrosternal support described. This is how my predecessor did it in the past, with classical steel wires and a little Gore-Tex prosthesis under the sternum. And this is how it looks like on a CT scan, for example. So the Gore-Tex doesn't go away. Nowadays, we have more nicer fixation plates, so you can avoid the distal net to support the distal part of the sternum. I call it the butterfly plate of Biomet. It's a angle stable screw fixation that you can put on the level just above and below the level of cutting your sternum and the sternotomy. And this is how it looks like, the pre-X-ray and the post-X-ray, where the butterfly plate is there. We're now 4 years down the line, and she's doing very well. With this result, you can see, even for a young woman, that this is a major improvement of the chest wall protrusion. We use also different plates, especially in this older gentleman of 28. I thought that the butterfly plate would be not as rigid. And here, after a transverse osteotomy and a wedge resection, we have put 2 LCDCP plates, again with corner stable screws, but also with some redirection screws to get the sternotomy well put together. More lately, also 3D printed materials became available, and these are 2 examples of a realized case and a theoretical case. On the left side, a complex redo case with a courtesy to Pieter Jan van Huistee of the Hague Hospital, and on the right side, a more theoretical exercise that we did for a patient with Poland syndrome. Here, these implants are actually printed in also titanium, but you see here a 3D structure making a full thickness of the ribs, but it's actually completely hollow, and it resembles the flexibility of the chest wall. Coming to almost the end of the implants is that the Abrahamson procedure we perform as well here in Leuven. And okay, it was an Argentinian bar. Then we embarked on the bar of Mustafa Yüksel, who designed his bar in Turkey, but because of some commercial reason, this stopped. And now we are very happy that MedExpert has designed the universal pectus system, where they actually have redesigned the Ribas stabilizer, which used to be a hole in the center. Now they have provided 4 slips, and it's depending right side, left side. I'm convinced that it will also cause less ingrowth on the rib where the stabilizer takes support to, but actually it's not officially, but you can, off license for now, do the Abrahamson procedure with these materials, as the slips have been provided to make the length around the rib with a steel wire fixation as short as possible. And the screw hole foresees you to adjust the bar in steps of about 5 millimeters to have a better compression of the carinatum. So, and this is a very nice transition to the last part of my talk, where we will talk about innovations in techniques. And we'll start this with 2 other questions. So if I can have the 4th question, Clemens. So what do you do in complex or deep pectus excavatum? Are you familiar with no elevation device, xiphoid elevator, some sort of craning, vacuum bell, or other techniques? So when we see that by the time more people state that they have some sort of craning available, but still about half of the attendees is not using any elevation device. And then we have about 10% of people using a xiphoid elevator. So let's go for the last question before I embark on the theme of craning. Which pain strategy do you use in your institution after pectus surgery? PCA, PCIA, only oral meds, or cryo nerve block? Also, multiple answers are possible. We see that half of the public is relying on the good old epidural, and I think there's nothing wrong with that. we see that cryonerve is not widespread yet, and I hope that this talk can be a little step forward in getting to know what to use when. So what are the challenges in a deep and an older pectus excavatum? The heart is in the vicinity of the sternum, as you know, because that is why we do the operation. And so one should be cautious not to injure the heart, as we see here in the movie provided by Professor Ribas of Sao Paulo, where an erroneous introduction of the mediastinum led to a dramatic bleeding of the heart by perforating the right ventricle. So we should avoid this because these are young patients. Forces on the highest entry point can be very high, especially the deeper your chest wall is and or the stiffer your chest wall is. The lever here on this point will be extremely high, and hence you risk to tear out the intercostal muscles. That is even more at risk when you finally made it to the other side without an injury to the heart, when you start levering and lifting actually the sternum on top of your introducer, then the forces here on this point will become even higher. And as such, the intercostal muscles, as I already alluded to, will tear out. You will lose the lever of the bar, and instead of the position of the purple bar there, the pectus will not be completely lifted, and then the bar will go down and will maybe again touch the lungs or the heart. And why is that? Because in this 3D model, you see that the ribs are not vertically, not horizontally, but they are oblique. And as soon as the muscles are stripped, the bar tends to slide in, at least on one side. Bar rotates even with a stabilizer. This is not always possible to prevent. And that is extremely important to know that in the adult patients, you see that the strain of the reposition of the sternum is transferred over the whole circle of the costal arch, whereas with a child, where the chest wall is still very flexible, these elastic parts of the anterior chest wall take over the forces. And this is shown here. The adults experience a lot more stress on this part of the anterior chest wall in comparison to youngsters. Obviously, there are different ways to lift your sternum. Xiphoidal access, like you would do to do pericardial detamponade. Miguel Tede already described the use of a Langenbeck in the past, making 2 nicks in the chest and then lift the sternum. And also Frank Martin Hecker, the big proponent of the vacuum bell, also described to use this to lift the sternum intraoperatively. One of the most important proponents of the crane that put it on the map is Jung-Yo Park of South Korea, who described his technique in 2008 with this type of retractor. And this was also known with some more variants, and then was picked up again more recently. Here you see some variants also with this type of shackle. And more recently, Don Jarzewski is still very known in our community to take care of a lot of adult patients, really came up with a thing for adult patients. This is the game changer. And indeed, this is the Rolltrack Skyhook retractor together with a bone clamp, already some time ago described. And also more recently, a variation with a Rolltrack and a retrosternal hook was described. Here you see some stability issues that I think that can be there when you use only one pole. I think if you use 2 poles, you have a more rigid system for the crane, but when the pole is just next to the deepest point, then it's in the way. And if you put the poles next to the head, then yeah, you cannot lift anymore. So we came up with a system that can hang over the patient, where you can attach your crane to. And this is the crane that I used for quite some time now, the Thomson retractor, the first version with a hook and a steel wire through the sternum. Now, more recently, we have the pectus assist that became available, which is basically a plate where you can address more than one metallic wire. And the advantage is that the metal wires go directly from the skin to the retractor plate. And here you see in this movie how the sternum is nicely elevated before we put in any bars, before we do any crossing of the chest wall. The big advantage is that this system was already CE approved when I sought some help of the company, and as such I could immediately use it in my hospital in Europe. They're very strict on these type of matters. Park again came up during the chest wall session last year in The Hague with his screw technique, mainly to replace the steel wires in the sternum by a screw. You have to make a nick and then bring the screw in, and the screw is then attached to the crane. This is the first version, and now he came up with the core screw. For the sake of time, I will skip the movie. He also has the flare compressor, which he used to compress flaring of the ribs. Now, the pectus assist, actually, if you turn it around, it also has a compressor and it works in this direction. So I use it also for my Abramson cases. Almost to the end of my talk, total chest wall remodeling. Again, the name of Jung-Yo Park should be mentioned because he came up with this thing, but more and more advanced surgeons are taking this over. And what we aim for is to get a full redesign of the chest wall. And especially in an asymmetric case, this is very important to consider that only with one bar you might not having a sufficient regain of your chest wall deformity. Here you see some changes, and in this patient, for example, we had to use 3 bars, and that is also known as the XI bar, and this is one of the techniques to acquaint for a total chest wall remodeling. Also the centrist procedure, the Park version, where you can put 2 bars over the one above, one below the sternum, and so that is hence the name sandwich. You can do it also in a different level depending a little bit on the implants you use. And then last but not least, also the cryoablation has found its way, especially in adults, but more and more it's also used in children, where we will cause an axonotmesis by applying a probe at a very cold temperature based on liquid nitro oxygen, and the tip cools down for 2 minutes, causes a temporary axonotmesis, and after 3 to 6 months, and that is varying according to age, the sensation comes back. But obviously your patient will have no pain for about 3 to 6 months. And in this type of patients, this is very nice. This is a young man of 41 years old, where I had to use 3 bars in a row. And this is a 3D scan of before on the right side and a normal, if you ask me, scan on the left side. This patient had cryonerve block, and these are green plots of our classic patients that still received, adults also that received epidural analgesia. And this is my experience of 4 textbook patients, where you can see that patients went home on day 2, on day 3, or maximum day 4. So a lot of gain in length of stay at least, but also very causing a lot of comfort when patients are at home. Let me conclude by telling 2 words on bracing. Close compression orthesis does not work, but when you have a wider orthesis, the chest can expand, and as such, the oversized chest wall can escape to the lateral parts. Marcelo Martinez Ferro was the big proponent of the dynamic compression system, and he keeps on making new invention on this rather relative simple system. And lately he came up also with an ongoing pressure assessment. You see that variants of this system came onto the market, some from Turkey, some local produce in the UK. We also embarked on the bracing therapy the last couple of years, but we have to use, because of reimbursement issues, we had to make our own bracing, but it's the same philosophy, 2 orthesis shells with an open space here so the chest can expand, and this is produced by Vigio Otto Bock, which is also active in Germany. This is an example of a patient that was treated with this type of brace, about 26 weeks wearing day and night, and then you see again a normal chest. So let me come to my conclusions. On my first slide, I would like to state that from simple pediatric pathology, we are now treating more and more complex and also older patients. And it's a vicious circle, because we show more interest in pathology, the industry is more interested, they make new implants, and they enable us to do more complex cases. Secondly, pain is still a working point, and I'm very happy to be able to share that cryo will be a game changer, especially in the advanced adult and deep cases. And less we see detrimental complications thanks to better visualization and technique optimizations like first a higher bar and using the traction and the crane technique. We are working in a niche surgery that is becoming more and more complex, so the experience is very important as to be able to do these fancy things like chest wall remodeling. To conclude, I would like to thank you for your attention. I would like to invite you to the chest wall session in about 3 weeks' time, to the C week, which is the high mass of this type of surgeries, and to the course that we are running again in the end of September here in Leuven. Thank you once again, and I'm open for a couple of questions.
Thank you, Hans, for this really detailed and comprehensive overview on all the aspects of pectus surgery. Time is already a bit advanced, but we have time for a few questions, so please use the chat function. Until people are coming up, I have a question regarding 3D reconstruction models. They have become very popular in like segmentectomies, and it's an obvious application to use them for chest wall reconstructions. You've shown a few examples where you used them before and after. Do you actually apply them for planning of the surgery as well?
The big difference with lung surgery is that for lung surgery, you base yourself on the CT scans. The DICOM images are transposed. Here, the 3D scans are usually made by an external scanning device. So it's 3D, but it's from the outside. For now, I think 3D scanning is still finding its place on where in the diagnostic and clinical algorithm it will be, but I'm pretty convinced that if more research will come out in the foreseeable time, we will find some way as to avoid some CTs. And if we have some similarity studies like the colleagues in Heerlen did, that you can make an estimation of the cardiac depression based on your external Heller index or correction index, that's maybe better, then I think we can avoid also some CT scans. Where it will be able to completely replace the planning on a CT scan, I must say on my adult patients, I still want to see where the rotation of the sternum is, because usually due to the subcutaneous tissue, that is less easy to see.
Jose Rivas de Campos is asking about the number of bars to be implanted. Is there tendency towards more bars, or can you add any considerations on that?
Yes, there is a tendency to more bars, and especially in all the patients like the image that I've shown you. It's not always possible. I did a lady with a memory breast prosthesis, and that limits your options. But in the most ideal adult cases, you put at least 2, maybe even 3 bars, and the XI bar is usually a possibility. But you need to be able to let you lead by how the chest wall will remodel by putting your introducer. So I cannot say I do 2 chest wall cases the same. The deformity determines also a little bit where the bars need to be, but definitely more than 1. In adult cases, 2 is the minimum.
Maybe a question on the functional outcome. You've shown some detailed data on the cardiac function, echocardiographic evaluation. Are there any detailed data on the pulmonary function tests as well?
There are some data available, although it's less clear what we should look for. A simple spirometry, for example, will be insufficient, as that is not a test done under exertion. A cycloergometry gives us a bit more guidance. However, this is evaluating 2 systems together, working together, the heart and the lungs. So also there, we still need to find a coupling between the clinical cases and more technical assessments.
Maybe can you add some consideration how long you would leave the bar inside, or is there any minimum time before it can be removed?
Classically, I leave the Nuss bars in for 3 years, Abramson bars for 2 years. In adults, I have inclination to let them in longer, as long as they don't have any problems with that. I want to make a little comment on Dr. Bechet, that in most patients there is no need for CT scans. Especially in adolescents, I never do CT scans, so I hope that can reassure you. And luckily, my insurance are not chasing me for reasons why I should operate on these patients. But in adults, it can give you some more insight in also what's going on inside. Usually they have smoked, maybe some cannabis. And if you then want to tackle or avoid at least some air leak from bad emphysematous lungs, it will not change your pectus surgery, but it might add some extra lung care.
Okay. Yeah, thank you, Hans. Our time is up for this excellent presentation, and thank you for all the to all the participants for the nice discussion and for taking part in this webinar. For next year, we will have some technical innovations here as well. We will switch to the Zoom platform, and we will announce the next series of webinars at the upcoming annual meeting in Milan. I hope you're all going to participate, and will let you know about the details of the upcoming webinars there. So the scheduled date for the next webinar is 9th of October, so you can already save that date in your calendar. And at this webinar, the topic will be esophageal surgery, and it will be covered by Xavier Benoit Journal. And I hope to see you all there as well. Thanks for today, and enjoy the rest of your evening. Bye-bye.
Bye.